Hello guys, very good evening. Hope I'm audible and visible. First of all, who I'm meeting for the first time today, very happy New Year to people in different parts of India. So today's lecture, though I have named it as Mixed Bag questions, is going to be more of what to do for the next upcoming 30, maybe a month, right? We have more than a month literally. So we'll see what to do in the upcoming month and where to focus on. And if you have any queries in your prep, we'll go through it. And at the end, I'm going to discuss whatever which came in the NEET PG 2021 in the pathology section to make sure that the NEET exam is not a difficult exam, right? We just go through it without any bias. We'll have a look at the questions. We'll just try to retrospectively solve it. Though we have the existing knowledge, I'm just going to use the basic knowledge what you had in undergraduate time, and we'll try to solve it and see that NEET PG exam is not really a difficult exam. Please don't be much worried about the exam. The stress factor and the fear factor is something which is going to take your marks away rather than the lack of preparation, right? Okay, so I hope you have registered for this, enrolled for this. It's going to be an all India mock test with a rank prediction, and I hope that will help you to see where you are aligned in your upcoming exam. Fine. And this is in subscription for Unacademy Lite. So this is kind of something which is new for Unacademy, where you will get like the QBank and test series alone, barring the videos, and we are trying to rebuild the QBank. Hopefully we've got a approval from the team as well, so we'll be starting it, and hopefully by the time when your next NEET PG exam results come, you'll have a completely updated QBank, including all the grant tests, PYQs and everything. And I hope PYQs are visible for every user now. If you have any errors in PYQ, there is a group for the feedback group for the NEET PG students, so do let me know, or anyone else in the group let us know. We'll definitely change whatever errors is there, if at all, if it is there. Fine. Okay, and this is MBBS Prof. This is a thing which is we have started only for the first year students. We'll soon start it for second year students and third year students as well, hopefully. So this Prof, it's going to be an in-depth reading rather than just covering for the NEET PG exam. We'll be coming with recorded lectures and live lectures soon, and you have lots of batches if you're a subscriber. If you want to subscribe to 1 month or 2 month course, you can use any code what you have, or you can use Pathological, right? So as I was saying that today's discussion is more on the base on how to prepare for the upcoming exam. If you have any doubts to what to do for the next 1 month, do let me know. And we'll see at the end we will be solving the NEET PG 2021 pathology, and make sure that NEET is not a difficult exam. It's a very, very simple exam, fine. So first thing, like what to concentrate, right? This becomes a very huge issue, especially in the last 1 month. So should I concentrate on a subject which I don't know, or should I concentrate on a subject which I know? We'll try to dissect the NEET PG blueprint, whatever is given to us by the NMC, fine. And let's see where, if you concentrate in which subjects, you're going to have the maximum yield, right? I have divided them into subjects with maximum weightage, subjects which are not linked to others, this is very important, and the remaining, right? So my focus is I want you guys to focus more on the first 2 slides, where subjects with the maximum weightage and the subjects which are not linked to each other, fine. We'll try to cover that. If you have the NEET PG thing before a couple of years, it was 300 questions, right? And the blueprint for 300 questions was perfectly laid as part A, part B and part C. Then they changed to 200 questions. They didn't have exactly a very good way of approach for that. Neither the NMC nor the exam council gave us anything go at that. The only thing was it will be a shorter exam, and it will be the same duration of time, but a little bit less number of MCQs. So considering the 300 question pattern, the weightage, that's 45 to 50% of the weightage comes in these 5 subjects. Medicine, surgery, OBG being the top, PSM and then pathology, right? So 45 to 50% of them are going to be in these subjects. So if you want to ace the exam, you cannot leave any of these. And if you look at them closely, path is definitely related to medicine. Surgery also is related to OBG to some extent. If you take PSM, again communicable, non-communicable disease do come. That also is linked with medicine. Surgical aspect, though it is very less. OBG also, quite a few things come in the PSM regarding the programs and everything, fine. So you have to decide to first finish these 5 subjects in the next upcoming 1 month. That should be my first goal. Later on we'll see what to look for it in the next part, right? So second part is subjects are not linked to each other. Like I said, that pathology is very well related to medicine. Surgery also is related. OBG also is related to some extent. But when you take general pharmacology, I'm not talking about the systemic pharmacologies where you read about the drugs. because predominant of the drugs, except for the half-lives and everything, mechanism of action, less everything, the indications will be covered in medicine, will be covered a little bit in OBG, surgery, as well as in your PSM, right? So the rest of it, again, same goes with micro. You'll definitely read about cholera when you read about Vibrio cholera, right? It's more or less overlapping. It's more of a syndrome. Which part of systemic microbiology will be tough for me is the oxidase positivity. Those part will be tough. Rest of them, when I have a more of a scenario-based question, I'll have one clue, subtle clue coming from my medicine. But when you take general pathology, like bacterial replication, those are not linked to other subjects. General pharmacology, where you have the trials, or your phases of studies, or your kinetics, your metabolism, the pharmacogenomics and pharmacokinetics, they are not linked with any other subject. Which means even if you excel this, you cannot do anything to this. Anatomy, though it said that there is lots of overlap in anatomy with your surgery and orthopedics, actually there's not much of overlap, right? So whichever it doesn't have overlap, more of an factual based question anatomy, you have to read them. Physiology, there are quite a bit of overlap in physiology with general medicine, but when it comes to question, they ask about ECF, ICF, it's not there. They ask about problems, it's not there. Lung volumes, yes, it will overlap, but majority of the physiology might not overlap. Biochemistry is one which never overlaps with any other subjects, right? How many of you listening to this, for you biochemistry is difficult? Is there anyone listening here who say the biochemistry is difficult for me? Great. So biochemistry is definitely difficult for quite a few of them, right? So when you say biochemistry is difficult, and biochemistry has very little overlap, inborn errors of metabolism to some extent in pediatrics, but generally it doesn't have an overlap. Most of the cycles, most of the enzymes, so you have to read them. Just giving concentration on biochemistry, only you have to read them. And ENT ophthalm, they don't have much of an overlap. Same with neonatology, right? Pediatrics will have an overlap. When you take pediatrics, a little bit of cyanotic and cyanotic heart disease might not have, but in general, pediatrics will have an overlap. But neonatology is not covered anywhere. Same goes with forensic medicine. So the second type which I want you to read after finishing these major subjects is these. So when you complete this, which will take care of my 80% of the exam prep. So this is going to be my first target. So once you finish this, the rest of them, I'm not saying that these are not important, but I'll keep this in the order of importance in the third. Micro, that's systemic microbiology, pharmacology, the drugs, pediatrics, apart from neonatology, and the short subjects. This I have a totally different take on. What has happened over the period of years is, see, I'm being in the exam prep for the past 10 years. The first book I wrote was in 2012. The short subjects has the same amount of importance over the period of years from 2012 to 2022. It's been having the same importance. But what has happened over the period of years is, since students like, if some of the students like orthopedics, they put more effort in reading orthopedics. If it's like radiology, you put more effort in reading radiology. Same goes with dermat. This might be your seat of choice, doesn't matter. But when it comes to an exam, I want you to be a little bit practical. Skin, anesthesia, radiology, psychiatry, and ortho, all of them are important because the questions which will be asked will be easy. I'm sure all of you will agree here that in your undergrad days, you must have never had much of an exposure to this. So don't put much effort on that. If it's anesthesia, you can take any exam paper in the past 10 years for anesthesia. One question will be on the airway. One question will be on the ABC maturation. One question will be the oxygen pin index. So I have very few targeted areas where questions have been repeatedly been asked. Your capnogram, succinyl choline. So these are the places where questions have been repeatedly been asked. So it's very easy for me to crack. Same with skin. One bullous disorder, one tinea, one psoriasis. So erythema nodosum, erythema marginatum. They are very, very specific. Radiology, though it has very much high importance in diagnostic medicine, when it comes to entrance prep, do you agree that medicine people talk about radiology image of CT and MRI during stroke and other lesions? Extradural hemorrhage, yes. OBG will talk about the twin placenta, your snowstorm appearance everywhere. Surgeon will talk about all the intestinal x-rays and abdomen barium enemas and everything, yes. Again, there's lots of overlap. Spending time on radiology will be on the radiation physics, that none of them will talk, and the radioisotopes, that none of them will talk. Do read, concentrate that part in radiology and read whatever notes you have. Rest of it, there'll be lots of overlap. You need not spend much time. And having said it's a short subject, they won't go in depth and ask in radiology. Nor same goes with anesthesia, skin, psychiatry, and orthopedics. It'll be superficial, which more than enough knowledge you have in all these 4 subjects. Just because this is your bread and butter in future, if you want to take any one of these subjects in future, don't concentrate much for an entrance prep. Entrance prep, it has less weightage, so we'll keep it in the last. Fine. Okay, so next is, this is very important, so I want you to tell. Individualize your prep. How many of you have listened to a topper's interview who's listening here? Almost everyone must have listened to a topper's interview. Yes, most of them more than once, some of them on a daily basis as well. What do I mean by individualize your prep is, you have listened to an interview, right? So when you listen to an interview, what happens here is, you try to fit into the topper's shoes. That should never happen. This starts from the starting of your prep till now. You should never try into a topper's shoe. What I want you to do is individualize. You have 1 month here left for your upcoming NEET PG exam. If you're targeting this NEET PG, do whatever is working for you till now. If I am going to say here, do this, do that, again, don't go with me. You must have fit into some curriculum for the past 6 months or 8 months. Do the same thing. You must have been strong in some, you must have been weak in some. Based on that, modify your prep. Always individualize. If I'm going to go with the same rule that, okay, this is the last year topper did, it may not work with me. This is true for everything. Even the platform what the topper did might not be okay with you. The test what topper wrote might not be okay with you. Go with whatever you are comfortable with. Waking up in the morning, that's what the topper told, need not be the same for you. Wake up whenever you wake up. Just make sure before the exam, 9 a.m, you should be brisk enough, right? That's the only goal. Apart from that, do whatever suits you, fine. So what to do on the exam day? Because exam day approach is one thing which might totally topple you. You must have read till that time very sincerely for the past 6 months. On the day of the exam, if you're stressed, everything goes away, right? How many of you listening to this have definitely had palpitation when the GT time slowly goes 1 by 1 minute slowly? If you have given a mock exam, if as a timer close to the exam, it will keep on reducing, right? If you're given an NACT or a NEET PG, the timer keeps on reducing before the screen opens, right? That time you must have an extremely high palpitation. That is one of your biggest enemy rather than anyone in the world. That stress kind of clouds our thought process. So how do I prepare for my exam day? The first thing, the major problems for me for the exam days, the major thing is stress. So how to handle stress? Right? All of you must have had stress in your life, and all of you must have handled this, right? At least for a person of your age, in the mid-20s, the maximum stress would have been to talk with your girlfriend or a boyfriend, right? If you're a boy or a girl. So that is the maximum stress, right? So if you handle that stress that's in your personal life, exam stress also can be handled. The way to handle is to break down the stress. This is where my GT comes into play. Don't overdo the GT at the same time. Write one GT. If whatever GT you're trying now, the reason for us to keep the All India mock test at 9 a.m. in the morning is same. If you're going to write the main exam at 9 a.m, I want you to get used to, at least from now on, whatever GT you give, it should start at 9 a.m. So I'm kind of telling my body, okay, at 9 a.m, I'm subjecting myself to a little bit of stress over the period again and again. Whatever tests you write from today onwards should be at 9 a.m. Any practice test, any subject-wise test, 9 a.m. So 9 a.m. daily, I'm definitely inducing my catecholamines, because any test you write, you'll have stress. Slowly and steadily, I'm getting used to it. Over the period of time, for sure, till the exam day, you cannot eliminate the stress. Like eliminating stress is zero, impossible. If you can do that, please teach everyone else. I can definitely reduce the stress by repeated practice. Today is April 15th. Till your May 15th, keep it a thing that every day 9 a.m, write a test, be it 10 question or 100 question or 200 question, doesn't matter. Do attempt a test at 9 a.m. from tomorrow onwards. 1 month you do it, you will get accustomed to it. That's the best way to beat stress. The second thing which I want you to do for the exam day is sleep. This spoils a lot for many people. Most of us are night owls, right? Definitely most of us are night owls, right? Unfortunately, we'll blame it on our internship, but we know the reason is not internship. The reason is Facebook and mobile phone. Most of us are night owls. So when I'm going to sleep at 1 a.m. in the morning, right, and I have an exam at 9 a.m., thanks to our NMC or your MCA, that they will keep the exam center easily 20-30 kilometers away from your home, minimum. If they have kept it near to your home, great, you are in luck. So I have to go to the exam hall at least like half an hour before the exam hall. So for me to wake up, I need to wake up at 7 a.m. So if I wake up at 7 a.m., it should be decent enough for me to reach the exam hall at 9, right? So if you sleep at 1 a.m., it is literally impossible for anyone in the world to have concentration for continuous 3 years from 9 to 11, 12. It's impossible. So you have to alter your sleep cycle. If you're sleeping for, let's say, more than after 12, from now itself, try to reduce it. You cannot do it close to the exam. You cannot do it in a week. You can never do it in a week. So let's say that if you're sleeping at 12 or if you're sleeping at 1, now reduce by 15 minutes per day. Again, reduce by 10 minutes next day. Reduce by 10 minutes next day. By this way, if you can do the same thing, reducing 10 minutes every day, you can reduce 2 hours. I want you to make sure from May onwards, you will sleep at 10 p.m. 10 is a very ideal time. Sleep at 10 p.m. If not, half an hour more, not beyond that. Keep your mobile phone in the next room, lock it, switch it off, remove the SIM, whatever you want. At 10 p.m., try to sleep. So when this gets accustomed, again morning, you will have a perfect way, a clear conscience to write the exam. That's very, very important on the day of the exam, right? And what is the exam testing? There's something which I like, right? Tell me honestly, there are a few of you watching here, which is problem for you? Getting more negatives or not able to attempt enough question? What pulls your mark in a NEET PG exam? You must have given a grand test for sure. What do you think pulls down your mark in an exam? More negatives or less number of correct answers? Okay, SN has gone with negatives. Right. For quite a few of them, you will either fall into these two categories only. I'm getting more negatives. Most of them will be in this category only, I hope, right? Or I'm having less number of correct answers. Right, so exam is not testing your knowledge. So you have to be clear with what exam is testing. Exam never tests your knowledge. None of the competitive exam tests your knowledge. They test your attitude. Because knowledge overall is the same. If you have a Gaussian distribution, I'll have outliers always. 5% here, 5% there. Rest 90% of the population will have the same knowledge only. 2 standard deviation. PSM helps you. So what is my exam testing and why few people are extremely successful and why few people are not is exam tests your attitude. So what do I mean by exam testing your attitude is, let's say that you clear this exam, you will get an MD degree or an MS degree or whatever you want. You will sit in practice, you will sit outside here, put a clinic or go to a hospital. So I want to test the doctor in you, the attitude in you, not the knowledge. Knowledge you'll definitely acquire over the period of time, you will for sure. So what do I mean by testing knowledge is, let's assume I'm going to divide people into 3 different groups. Fine. That will ease us and say why is exam testing these things. Fine. The first group of people who will write approximately 60% of the questions. They'll write only 60% of the questions because they'll say that, okay, I know 60% of the questions. They're not risk takers. The second group will write close to 100% questions. They'll write like if there are 200 questions, 198, 199. Just for namesake, they'll leave one. The third group of people will attempt close to 90 to 95% of the questions. This being the third group. I'll tell what is the major difference between these 3 people in the terms of attitude more than the terms of knowledge. If a person writes only 60% of the question, they cannot get an answer. Which means this person is very, very conservative, that they write only things which they know. Which means when you come out as a doctor, you're going to practice whatever you read in the textbooks. Okay, textbook, I had a perfect picture of cholera, I'm going to practice. I had a perfect picture of breast cancer, I know I will practice. I don't want them. They're not risk takers. when I'm not even okay to take a risk for an exam, definitely not going to take a risk when a person is there on the life, right? So I don't want this person to get an MD or MSc. This is one category which will be completely ignored. They will not be able to be successful in the exam. The other person who's 100% is they are overconfident. You definitely know that in any given exam, be it your GT or your INACT or Marrow Prep or Unacademy or NAMS or Bhatia, whatever it is, can I say that easily 5 to 10 questions you must have not even heard of? Very rare, very difficult questions. So what you do is you go and attend that also, which means you are extremely confident, overconfident. I don't want that mindset for a doctor as well, because when this group comes outside, what they're going to do is they will act and they will think like that they know everything. They will not refer, they will not ask the help of a friend or a colleague or a senior or a junior. They'll try to do themselves everything. Again, that's not the right attitude for a doctor. So they also will not get a rank. The person who will get a rank is this. This group encompasses, and I want you to be in this group, not for this exam, in a real life. The 60% which every MBBS doctor knows, they will write. Rest, let's say 30%, that's via integration. I know physiology, I know medicine, I integrate and I write. They'll attempt that as well. Rest 10%, they'll think that I have to leave some questions. You have to leave some questions. They will know when to leave, and when they know some in an exam, the most decisive competitive exam in life, if you're okay to leave a question, which means you know when not to step the gear. Okay, I don't know this. Beyond this, my knowledge stops. I'm not going to make an attempt. This is a person who will not be overconfident in a real life. I'm a pathologist. I know about pathology. If a person is there for a surgery, I'm not going to go and put suture at any point of time. I know my line. Beyond this, I'm not going to report. Even in pathology, I don't report many things because I know my limit. So if you know your limit, and if you are able to do whatever you are supposed to read, and the integration, that's the perfect combination of a practicing doctor, which I want, and your exam tests that. Exam tests mainly this in addition to your whatever your knowledge is there, fine. So see which group you fall into, and I want everyone to fall into this group. Hopefully that will help you, fine. Next is I hope you're able to see this. How many questions to attempt? This is a burning question always, right? How many questions do I attempt in an exam? Is it all 200 or 100 or 120 or 130? This should be individualized. When I say individualized, never 100, never 60%. That's there for sure. So I will divide them into 3 groups. Again, 95% of the questions I have to write, 90% of the questions I have to write, 85% of the questions I have to write. These are percentages, right? So if you think the exam, what you're writing is on an easier side, go for 95. Okay, that's a good one, Abisa. If you think the exam is on an easier side, I want you to go for a little bit higher percentage, because when you are an easier exam, more the questions you attempt, that's good, because most of them will attempt more questions, right? So I want you to be in the percentile. If you think the exam is on an extremely difficult side, attempt 85. Medium, attempt 90. Don't go beyond this. More than 95 and less than 85 is always dangerous. I wouldn't say that you will never get a rank, but it's always dangerous to be there. Borders are fine, but never attempt 70% of the exam questions and expect a rank. You cannot. 70% of the exam questions is 140 questions. That's good, Ibisa. If you attend 140 questions, you will definitely have 20-30 negatives. That will pull down your rank. Fine. So make sure you lie in this. So like Ibisa said, 184 is a good one, which is around 92%, right? So if you attend 92%, if your paper was a moderate paper, definitely you are in the goal of getting a good rank, right? So make sure you fall in this category, and that should help you to decide. This should help you to decide on the day of the exam, fine. Okay, this is one more thing, like what to start with. So what do we mean by what to start with is during exam hall, right? In the exam hall, some of them start with question number 1, some of them go with 50th question, some of them go with 100th question. If your exam has been aligned based on the subject starting from anatomy to orthopedics or radiology, then it's fine. If it was like a part A, part B, part C, it's completely fine. You start with whichever part you're comfortable with. You're comfortable with preclinical, paraclinical, or clinical, go with that. But a 200 exam question paper, I hope it is mix and match. It's mix and match. There is no point or no advantage starting from 50th question or starting from the last. Go with the first. If I don't have any subdivision, I would say go with first question, so that at least you will have an idea. Okay, I finished this much question with the timer ticking on. Fine. Okay. Before this, when to leave the question, I just want one more to add. The time spent in one question. See, this is very important. You have 200 questions, and let's assume that I have 180 minutes. I want to keep it 180 minutes, so I'll keep it as 180 minutes. So on average, I'll say that 45 seconds to approximately to 1 minute a question. When you have a question which you're not able to solve it within the first 10-15 seconds, the question is extremely difficult for you. Can I say that you can read a question in 15 seconds? Definitely you can read a question in 15 seconds, right? You can read a question in 15 seconds. If you know the answer, you will write in 15 seconds. You must have attended lots of polls in the Unacademy. You must have done that for sure. Yes. Sorry, excuse me. Right? So 10 to 15 seconds is like the first step for me that, okay, if you don't know that beyond that, try to reduce the number of time. Maybe skip that. Do not overthink there. The reason why I want to skip you is 15 seconds you read a question, I am not able to come to a conclusion. Skip the question. Maybe mark for review, come back later on. If you feel that there are more questions for mark for review in this method, it's completely fine. You'll have grant tests, try this out. If it works, implement in the main exam, fine. I would say that 15 seconds is enough for you to read a question, understand the question, come to an answer. More than 15 seconds, you don't know some link in the question, skip that, mark for review, and come back and answer. I want you to do this. Don't overthink, wait for 30-40 seconds, and then mark an answer, and then mark for review. No. When you mark for review, the answer should be blank. Don't mark an option and then put mark for review. Because when you do that, next time you will come, you will overthink. I don't want you to do that. Mark for review should be very simply used. If you mark something in the question, don't mark for review. Otherwise, mark for review, fine. And when to leave a question, right? This is also an important thing. My predictors for leaving questions, I don't understand the question. I'm not able to understand anything. The question itself I'm not able to understand. I'll leave the question. There's no chance that I'll get it correct, right? I am not able to narrow down any option. When I say narrow down any option, of the 4 options, for me, even after reading, it looks like all the 4 options are correct. Leave the question. Because chance of inky pinky ponky, there is 25%. Do not leave the question when you can rule out 2 options. Because most of you will be getting stuck in this, right? You can rule out 2 options, rest 2 options, I don't know what to do. In that, make an intelligent guess, see what could be the answer, and go with that. When you're able to rule out 2 options, yes, that you're in for the game. Definitely attend that. I'm not able to narrow down anything. Leave the question. I'm not able to understand it. Leave the question. A completely new ideology. Leave the question. A number which you've forgotten. Leave the question. You cannot remember a number. Either you remember it or you forgot it. If you've forgotten, it's gone forever. Don't come and write the answer. Fine. Okay. So these are things. At least for me, it has worked. So leave the question in this respect. Fine. So let's say. So these are few things which I want you to keep in mind. So if you are giving the upcoming NEET exam, let's discuss a few things which came in the last NEET exam without any bias. I'm sure you must have read this question and anything. I want you to be fresh, think fresh, and try to comment on the answer, right? Just finish in the next 10-15 minutes. Quick review of the NEET PG 2021 pathology questions alone, fine? Comment on the answer. We'll try to solve it without any existing knowledge which is required for you. What do you think is the answer? I'll mute myself for 30 seconds. Answer? It's a simple one. All of you must have read this question before. Just answer it. It's a simple one, right? These are all PYQs. Okay, SN started with B, aplastic anemia, right? This is a very simple question, right? Let's see if this is the first time you're seeing the question, we'll try to rule out options and see which is the correct answer. I don't want any existing knowledge of yours. I just want something, right? Recurrent infections, bleeding gums, and the patient has pancytopenia. Bone marrow biopsy shows no megakaryocytes and filled with fat globules. Myelodysplasia will have a marrow which will be mostly an hypercellular marrow. Myelodysplastic syndrome or myelodysplasia. I have no comment on dysplasia in the question, not the answer. Tuberculosis, if at all if it is tuberculosis, microscopy should have had granulomas. No comment on that, not tuberculosis. PNH, right? We'll use your existing knowledge to solve this. PNH comes under which subtopic in your RBC chapter? Does it come under your nutritional anemia or hemolytic anemia? PNH comes under nutritional or hemolytic anemia. It's a very basic thing. It comes under hemolytic anemia, right? So if you read PNH under hemolytic anemia, whenever there is hemolysis, can I say that bone marrow will proliferate more? That's a very simple logic. When there's hemolysis in the periphery, bone marrow will proliferate. That will automatically compensate by reticulocyte count, right? So if it's an hemolytic anemia, bone marrow should be cellular or hypocellular. It has to be cellular. It cannot be hypocellular. So this is not the answer. This is not the answer. This is not the answer. I just want you to think, that's all. It's a very, very simple question. It's not a difficult question at all. Even without the existing knowledge of what is aplastic anemia, I can rule out the three and I can come to the right answer. This is what I want you to do. You can do this if you are having a peace of mind, no exam stress, and just a clear thought. Fine. Next. This is also a very simple question. Read through the question. We'll discuss the answer in a minute. Answer. It's a simple one. This is also a PYQ. I'm sure you know the answer. It's okay to comment the answer even if you know. It's a new reading again, reinforcing the fact which you already know. Okay, we'll go to the question. The catchy point here for me is the mean corpuscular volume, right? So MCV is a catchy point, which is 115. When I have an MCV of 115, my options are very, very narrow, right? I have macrocytic anemia. Acute blood loss is not macrocytic. Autoimmune hemolytic anemia is not macrocytic. Both are normocytic anemias only. Macrocytic anemia, the only possibility here is B12 or folate. That's all, right? So B12 deficiency is very rarely related to your food intake. B12 deficiency happens only in vegans. It will not happen in anyone else. Vegan in sense, they should not have any meat, they should not have any milk, right? So if it's there, then yes, B12 is possible. Most of the B12 deficiencies are not nutritional related. They are antibody related. The predominant cause is your pernicious anemia, right? So here I have complete lack of fruits and vegetables. Green leafy vegetable is a very, very important source for folate. When there is no fruit or vegetable in the diet, folate automatically goes away. So it kind of relates to your folate deficiency, fine. So again, by ruling out, these two are gone. And B12, there's no history of vegan, so my answer is perfect, right? Read this, we'll come to a conclusion. Okay. Answers A. Abhimanyu started with A. Anyone else? Kani has gone with A as well. Okay, to answer this question, it's a question based on iron profile and iron deficiency anemia, right? There are few easy ways to solve iron profile questions in IDA as well as in your anemia of chronic disease. So IDA is, there are four basic parameters: serum iron, you have serum ferritin, you have TIBC, you have transferrin saturation. Right? These are the four basic parameters for your iron profile. Fine. So in case of iron deficiency anemia, all of the following are increased except. So the question is, which of the following will be reduced in the case of iron deficiency anemia? That's a question that's been asked. What do you think will happen to serum iron in case of iron deficiency anemia? Serum iron obviously will be reduced, right? So transferrin saturation is directly linked to my serum iron. So if I have 5 transferrin molecules with 5 iron binding sites, if there is only one iron, obviously only one side will be bound, and so saturation is reduced, right? If you have 5, then everything will be saturated, right? So that's simple. So if my serum iron is reduced, transferrin saturation will also be reduced, right? My question is very simple here. Which of the following will be increased in case of IDA except my transferrin saturation, right? Next come to ferritin. Ferritin is a storage form of iron. Ferritin also will be reduced in case of an iron deficiency anemia. So that's straightforward, fine. Let's assume that TIBC is your affinity to bind to iron. Let's say, for example, you're not being given food for past 3 days. You're being given food today. Will you eat it with more affinity? Obviously. Which means when I don't have enough stores, I'm more hungry, I grab whatever I get. So when in iron deficiency anemia, if my serum ferritin is reduced over the period of time, what happens is the affinity to bind to an iron will extremely increase, right? So TIBC will increase. So TIBC will increase, transferrin saturation will reduce, right? So that someone is going to be reduced in case of an iron deficiency anemia. It's very simple logic. So I don't even want you to know what is RBC protoporphyrin, what is soluble iron transferrin receptor. Nothing is required. Even without knowing everything, I know the answer, which is transferrin saturation. See, this question, if you look at this question, it looks like something new, because before the NEET PG exam, we don't teach you much of these because it's not required for a day-to-day management of a case of an IDA. That's more theoretical, the C and D options. So even if you don't know about that, still if you know the normal basics, which is being taught to you from second year, it's enough for me to solve a question. So if some new point comes, don't get staggered. Okay, soluble iron transferrin receptor, okay, that should be the answer. Don't go and mark it. I don't want you to do that. You already know an existing fact, existing knowledge, solve the question based on the knowledge. Others, irrespective of whatever option it is, ignore that, fine? So now let's try and see what is an RBC protoporphyrin. Can I say that protoporphyrin is an intermediate in heme metabolism? Yes, it's one of the intermediate, right? So can I also say that if the outcome of heme is not proper, all the precursors will elevate? That is true for any enzyme reaction. If the outcome is not proper, all the precursor substrate will obviously elevate, right? For my normal heme to produce, do I also need iron? Iron is required, right? For my normal heme to produce, my iron is definitely required. If iron is not there, which is one of the key components of heme or your hemoglobin synthesis, heme will not be produced properly. If heme, which is the end product, is not produced properly, will RBC protoporphyrin, an intermediate product, increase? It has to increase, right? It's a very basic concept of whatever you have read in biochemistry. We're going to apply the same to understand what is RBC protoporphyrin. Fine. Next is soluble transferrin receptor. Let's assume that this is erythroid, a normal erythroid. Here I have 2 transferrins, fine, in a normal state. Because iron predominantly goes to my erythroid and helps in the formation of hemoglobin, right? So these receptors are my transferrin receptors. So what happens is, when a receptor has to come to the surface of an erythroid, there will be tiny fragment which will be broken down and it will go to the serum. So that is what I calculate them as soluble transferrin receptors. So in other words, soluble transferrin receptor is kind of an indicator for my transferrin receptor on erythroid, right? So this is the first part of the understanding. Hope this is clear. So whenever a receptor of transferrin has to come to the surface of erythroid, a part of it will get broken down and it goes outside. In other words, it's a simple concept like your C peptide. Whenever my insulin is produced, C-peptide breaks and goes outside, right? Same, almost similar concept. It breaks, goes outside, and that receptor goes on the top. So let's assume in a body, the patient has very, very little iron or no iron at all. When this iron amount reduces, can I say that my erythroid will be worried and it will increase the receptors on the top? So whatever little molecule of iron I have, I'm going to bind to them. Yes, that will happen, right? So in case of an iron deficiency, what my erythroid is going to do is involuntarily number of erythroid receptors will increase. It will definitely increase, so that even the tiniest molecule of iron present in the serum should be bound, and I'm going to use it in my production of hemoglobin, right? So if the erythroid surface receptor increases, what do you think will happen to your soluble transferrin receptor? Will it increase or reduce? As I said, it's like a thing for my transferrin receptors, right? So my TIBC, RBC protoporphyrin, as well as my soluble transferrin receptors will elevate in case of an iron deficiency anemia, fine? This is the entire understanding about the subjects of iron deficiency anemia, but even without knowing that, just my normal iron profile is enough for me to answer this question, which is transferrin saturation, fine? Okay. This is a very simple one. I hope everyone who attended this exam would have answered this. Options, answer. This is simple one. Pleomorphism, hypochromatic cells, all layers of epidermis are involved with disordered growth. The answer is perfect, everybody. It's dysplasia, right? When I'm having pleomorphism and disordered growth, metaplasia is not a possibility. Hyperplasia is not a possibility. Both of them are benign conditions, will not have any pleomorphism. Fine. When it's pleomorphic, hyperplastic, it's definitely either dysplasia or carcinoma. But as you guys know that carcinoma requires your invasion of basement membrane, which is not there here. So it's unlikely to be carcinoma. It has to be a patient. In case of dysplasia, it's not a carcinoma. Again, it's a very, very basic concept. The question might look like 4-5 lines. Doesn't mean the exam is difficult. It's a very, very simple. It was a simple exam, right? This is more of an application based question. I like this question. Let's see if you can solve this question. Answer. This is a very, very practical one. So I want you to answer based on a practical aspect, not based on a theoretical aspect. B, B and A. As I said, it's a very practical one, right? There are few questions which came in the last day exam, which is not based on the textbooks, which is more based on the approach what I do in a real life, right? So whatever you read in textbooks is not the exact way what we follow in a real life. So you have to understand that when you go to internship, you must have definitely understood that. In your textbook, you must have had a totally different way of approach. In a real life, you approach it very differently, fine? Just be one example for that. Like you guys said, the diagnosis here is very simple. History of fatigue, dragging sensation abdomen, enlarged spleen, peripheral smear source, leukocytosis will shift to left. My diagnosis here is going to be CML. So you have a patient with a CML. I'm sure some of you have answered lab score. Lab score is definitely useful for CML. When do you think lab score is important? Or in other words, to differentiate from what lab score is required? CML versus something else, I need lab score. What is the differential diagnosis which I'm dealing in terms of lab score? I'm going to deal, if I'm going to have a doubt with CML versus sepsis. Yeah, leukemioid reaction, or in other words, sepsis, right? Leukemioid reaction, in other words, is going to be sepsis. When you have a doubt between these two, I have to do a lab score, understood, right? Do you think with this history, is there any tiny bit of possibility of sepsis in this patient? In sepsis is where you get leukemioid reaction. Is there any possibility of sepsis here? Patient came to OPD, fatigue, dragging sensation abdomen. No, right? There's no fever at all. I don't have a fever at all here. When there's no fever for me, I'm not going to think of sepsis at all, right? So sepsis here is not a possible differential diagnosis. So when sepsis is not a possible differential diagnosis, I'm never going to use lab score. In other words, can I say that in any real life scenario, do you think it will be difficult clinically to differentiate sepsis versus CML? I'll answer your question there, Braj. Will it be difficult clinically to differentiate sepsis versus CML? Not at all, right? I can easily differentiate. So it means lab score is not useful in a real life. It is very, very important for an undergraduate to learn something about lab score, because in one point, if I'm going to sit in a lab without any clinical history, I might be required. So lab score is useful theoretically. Now practically, lab score has no utility value at all. I can easily diagnose sepsis, right? They've got sepsis, there will be hepatosplenomegaly, but sepsis will not cause a massively enlarged spleen. Sepsis is not one of the differential diagnoses of massively enlarged spleen. There are very, very, very narrow differential diagnoses for and massive splenomegaly. Sepsis is not one of them, right? And without history of fever, I'm not going to think of sepsis, or any localized infection, I'm not going to think of sepsis, right? PET scan. PET scan is also not important for CML because PET scan is useful to diagnose metastasis. That's use of PET scan to identify secondaries. Here my first diagnosis, the primary diagnosis itself at query, so I'm not going to go with PET scan. Immunophenotyping is also not needed. For CML, it's more of your chromosome analysis. Peripheral smear should be more than enough to pick up CML with basophilia and all those things. I'll come to travel. So definitely that's enough for me. Immunophenotyping is not useful, at least for CML. If it's an acute leukemia, yes, IHC or your CD markers will be useful, not for chronic myeloid leukemia, right? So FISH is definitely useful to diagnose them, fine. Rahul, your question is, if I got your question correctly, you are worried about whether leukocytosis is a feature of sepsis. Won't I have a confusion between that and CML, right? Yes, Abhimanyu. Shift to left in the sense immature cells are coming inside. In that question, that's what I said. So this is a lab differential diagnosis. If I had this question of this alone, I don't have anything else, no history at all. I have a question saying that peripheral smear, there's leukocytosis with shift to left. What is the next thing? I will do lab score. Since I have a patient here, since I have a history here, I don't think of a leukemia reaction with this history and patient. So I need not do a lab score, right? So in other words, in future, when you write a proper history, I will make many tests redundant. Lab score came because I don't have an history clinically of sepsis. I have only the image there, only the peripheral smear and blood there. With that, these are my possible differential diagnoses. When a clinical scenario comes, it's ruled out totally, fine. So I don't want a lab score in case of diagnosis of a CML, fine. Okay, great. Okay, read through this question, let's see. It's a simple one. C. Great. This question is kind of not exactly a PYQ. This question was asked previously in 2 more exams before the last NEET PG. So I do have lots of repeat questions. So if you're preparing for this upcoming exam, read at least 2-3 years of the past year's exam so that you will not miss any of the repeat questions, right? It's a classical case of Mallory-Halen or your Mallory-Denk bodies. Mallory-Halen or Mallory-Denk bodies is made of perfect cytokeratin. Cytokeratin is an intermediate filament. The difference between interfilament filament, actin, microtubule, fibronectin will be in the first chapter of pathology, right? In the first chapter of cell, you'll have all the difference. So it's an intermediate filament, so I can easily know that, right? I'm sure most of you will know the other part as well. What type of cytokeratin you see them in Mallory-Halen? Any specific number? Sorry. Any specific number comes to your mind? In case of cytokeratin? It's actually cytokeratin 8 and 18, right? Cytokeratin 8 and 18 are the subtypes which is seen in your Mallory-Halen body. Cytokeratin 8 and 18 it links to your hepatobiliary tree. When you have cytokeratin numbers, it goes based on the embryology. Cytokeratin 7 will be seen in your upper aerodigestive tract, 8, 18 for liver, little bit of bile tract. When it comes more to the pancreatic or biliary, it becomes cytokeratin 19, and it comes to your lower GIT, it becomes cytokeratin 20. Fine, that's how it is. 7 will be in your upper aerodigestive tract, which includes your digestive tract, salivary glands, and your lungs. 8, 18 will be for your liver, and maybe a little bit of overlapping gallbladder. You'll have 19 for your pancreas. I have 20 for your lower GIT. Okay, so this is how the classification comes for your cytokeratins, right? There are multiple other things as well, and I hope you know the difference between the table of cytokeratin 7 and 20 useful in diagnosing primary. That's also an important one, right? Okay, I hope you won't have a doubt in this question. This was one of the controversy creating question at the time of the exam, but I hope now it's clear. Answer: bladder or blood? Still we have a difference of opinion between bladder and blood. Bladder. Okay, see, we'll ignore this. Let's assume that there's nothing there. Exposure to some toxic chemical over the past years, right? Because benzene is the one which is taking our life, right? Exposure to toxic chemicals in the past years. Now with the history clinically, which fits inside? Bladder carcinoma or a blood carcinoma? A blood carcinoma in sense leukemia. Fatigue, multiple infections in the past year, which means I'm having anemia, cytopenias, right? So with just the clinical history, the only thing which I'm going to think of is in leukemia. You have cytopenias, right? Because of reduced WBC count, I have infections, and reduced hemoglobin, there is fatigue, right? If it is a bladder cancer, right, what do you think the presentation will be? The presentation should have been your hematuria, right? A painless terminal hematuria, that should have been the presentation, right? Benzene will come to it. It should have been hematuria. I don't have the history here, so unlikely to be an bladder cancer presentation, fine. Benzene and benzene, yes, useful. With this history, I don't want that. So see, you answer the question based on a fact of benzene or benzidine. You left the patient on the top. Patient on the top is very important than the fact, because fact you might forget, histories you might not forget. So please take care of the history. Fact we'll see later. Lots of time you'll have to read more fact. So don't answer a question on a fact when you have this on top. But if the person asks benzene causes what cancer, that time only the fact is going to help you. Like you guys said, benzene causes blood related neoplasms, leukemia and aplastic anemia. Benzidine causes bladder cancer. Benzidine and naphthalene causes bladder cancers, fine. Okay, great. Waste fellow, if I can tell you something like a brother, don't take it to your heart. Change your name, put not a waste fellow, right? No one here is waste, and you are definitely going to be an amazing doctor, right? If possible, change that. Okay, naming of you is very, very important, fine. Okay, next. Options, answers. D, it's a simple one, right? It's a very simple one. Hepatosplenomegaly, bone marrow shows crumpled tissue paper appearance. Answer has to be glucocerebrosidase and cautious. You have seen this, we must have discussed this n number of times. We're not going to go and read about it again, and just skipping to the next one. Fine. Options, answer. A. Anyone else? Great. Most of you have gone with thymoma. So what is the preliminary diagnosis here? Thymoma is fine, but what are we explaining in this question? Reticulocyte count of less than 5.5%. The person is having a pure red cell aplasia. That's the most important clue here. You shouldn't make a mistake here, right? The question says there is a mediastinal mass. This will not cause a mediastinal mass. Squamous cell carcinoma of the lung, yeah, kind of in the lung area, might not push into my mediastinum mostly. Non-Hodgkin's lymphoma can come in the mediastinum. Laryngeal carcinoma, again going into the mediastinum, is a bit unlikely, right? So for me, NHL is possible in the mediastinum, and also your thymoma is possible in the mediastinum. So to rule out these two, I have PRCA. So PRCA is a paraneoplastic syndrome seen in thymoma. So my answer here is thymoma. Thymoma can have many other paraneoplastic syndrome as well. In the previous exams, one more paraneoplastic syndrome has come and they think, what is that? What is the other commonest paraneoplastic syndrome asked in an exam relation to thymoma? I'm sure you know that. Myasthenia gravis, right? Myasthenia gravis is also very, very common in thymoma. Do remember that as well. Fine. Okay. Question, answer. Amazing, right? Kind of looks like a caterpillar, really, right? The caterpillar cell, though it's a finding seen in cytology, it really looks like a caterpillar. Very rarely you see them. I would at least don't want you to remember this caterpillar. But Ashoff never leaves us. Ashoff body is one which is classically seen in rheumatic heart disease. The 12-year-old kid with sore throat and murmur and the kid's parents, all those things are more important for me than the microscopy here, right? Don't go with the microscopy here. You have a classical case of a rheumatic heart disease, so I'm going to go with Ashoff bodies. These are caterpillar or Aniskov cells. The chromatin is kind of wavy like this, which kind of looks like a caterpillar, so it's called as caterpillar nuclei. Fine. Okay, right. Where this question also had little bit of controversy when the exam came out. Let's see. This is a very simple one. I hope you'll pick it up. Okay, Satvik has started. B, A, B. Others want to join? B again. B, right? Predominant of you for B, just a few of you for A, right? So this was a confusion which came when it came in the exam as well. So again, my history is very important. In addition to that, the image is also very important. Fine. So first for me is a patient with a hematuria evaluated and a cystoprostatectomy was done. Removing the bladder and prostate, it's not an easy surgery. It's a very, very, very radical surgery, right? Do you think for an hemorrhagic cystitis, which is caused by cyclophosphamide, you'll remove the bladder and prostate? No, right? Most common cause of hemorrhagic cystitis is cyclophosphamide. The maximum thing that I'm going to do is remove the drug and see what I can do, right? Malakoplakia. Which group of disorder will you classify them into? Is it a neoplastic disorder or an infectious disorder? Malakoplakia is an infectious disorder, right? So if it's an infection, what do you think should be the ideal treatment for malakoplakia? Antibiotics or cystoprostatectomy? I'm going to do I'll give antibiotics, right? It's a chronic infection because of defective in the phagocytic activity. So E. coli is the commonest cause. You give antibiotics that can be taken care of. It's a cystitis, it's an infection. I'm not going to do a radical surgery like this, fine. I have two other options. Prostatic carcinoma, I can do a surgery for sure. Urothelial carcinoma also, I can do a surgery for sure, right? If you're arguing that it could be a prostatic carcinoma going back into the bladder and growing like this. You can see here, there's a cut open surface of a bladder here. There's been opened here and you have a mass in the bladder. Mass in the bladder means it has to be an urothelial carcinoma only, predominantly. If you argue that, okay, a prostate cancer can go into the bladder, it's a possibility still. If you have a prostate cancer growing into the bladder, will the patient present with the urgency of micturition and all of them or hematuria? it's a prostate cancer. The primary complaint of prostate cancer is going to be obstruction to the urine flow, dribbling, frequency, urgency. Like your BPH will be the presentation, not a hematuria. And prostate cancer rarely grows like this into the bladder, right? Since there is a mass in the bladder in the open part, and the history of an hematuria, I'm going to go for a urothelial carcinoma. The only point against Malakoplakia is I'm not going to do a surgery for Malakoplakia. Malakoplakia doesn't have a mass like this. It will have yellow streaks. Malakoplakia is nothing but accumulation of foamy macrophages. It's not going to cause a mass like this. It just have an yellow streaks. That's all, right? Okay, we'll kind of end with this, the last one. So comment on the answer. I'll do it, Abhimanyu. I'll do it after this question. Okay, great. Ideally, this surgeon shouldn't have sampled the lymph node, right? Your lymph node and my hilar lymph node will be still black in color because we are breathing the air which is polluted with carbon particles. It's a squamous cell carcinoma which will not cause a melanoma deposit. If the patient has had a melanoma in the history, yes, sampling of the lymph node is very ideal because melanoma can also cause the blackish deposit. So it's anthracosis, which is a very common thing, fine? Okay, it's not the right answer. Hopefully we have changed it now. It's the bladder carcinoma, which is the right answer. Malakoplakia, you're not going to remove your bladder, fine? Okay, so I'll discuss about Malakoplakia a little bit in short. Let's see if I have some, I'll use this space. See, Malakoplakia is a chronic inflammation, fine? What happens in Malakoplakia is, the background is very important for Malakoplakia. A person should have defect in the immunity. Either the person should be immunocompromised, not able to, which can be acquired or congenital, or the patient's phagocyte function is reduced. Actually, the phagocyte function being reduced is the commonest denominator in most of the cases of Malakoplakia. The phagocyte is not able to eat the organisms and remove it. So here, the patients have infections. The commonest infection is going to be E. coli. The coliform organisms, Klebsiella can also be there, commonest being E. coli. So when a person's bladder gets infected with E. coli, the neutrophil will eat it, try to destroy it. Phagocyte will come, will try to destroy the neutrophil and the organisms. But they can't do it because phagocyte is not properly functioning. If phagocyte is not properly functioning and is not able to eat it, can I say that more number of phagocytes will come and crowd the area? Because one phagocyte came, not able to do the function, so many more cells is going to come, get recruited and will come into this place, right? So what happens here is, over the period of time, there will be lots and lots of foamy macrophages. Foam cells which will come to the area. Again, they also will not be able to clear the organism because they don't have a proper function. They can't clear the organism. So what happens, over the period of time, all these foam cells will accumulate in the bladder. So this gives, in the gross appearance, the bladder mucosa and yellow streaks. It's like your atherosclerosis. In atherosclerosis also I had lots of foam cells, right? So the gross appearance of bladder mucosa has lots of yellow streaks here. And this happens again and again and again over the period of years, right? If it happens over the period of years, can I say at one point there can be calcium accumulation inside the foam cells and can calcific deposits happen? I'll come to it, everybody. Can calcium get deposited in the foam cells over a long period of time, like a degeneration or a dystrophic calcification? It can, right? So these foam cells over the period of time, what they'll have is they'll have calcification inside this, and they are called as Michaelis-Guttman bodies. So Michaelis-Guttman bodies are nothing but they are dystrophic calcification seen in the foam cells, right? They're just calcific deposit, that's all. These are dystrophic calcification seen in foam cells, and it's a very easy way to pick up Malakoplakia on a microscopy, right? Abhimanyu, it's not exactly the lipid-laden cells. Do we call a normal macrophage also foam cells? They're also called foam cells, right? So because the phagocytosis function is reduced, the foam cells accumulate. The foam cells here, what I'm talking about is nothing but foamy macrophages, right? It's not the same foam cells of atherosclerosis with fat-rich cell. A normal macrophage also will have fat. There's nothing but accumulation of foamy macrophages in excess amount, which causes gross deposit and microscopic lab dysfunction, right? Okay, clear? So this is short of Malakoplakia, and the best way to treat is, since the patient is not able to eliminate the organism, I'll give an antibiotic and I'll definitely able to treat the patient, and it comes back. It's in cystitis. It automatically comes back to normal. Fine. Any other doubts? No other doubts? Okay. No other doubts. We'll call it a day for today. Hopefully you'll learn more together. I'll be starting the mixed bag revision for your upcoming NEET PG in Unacademy app soon. I'll give you a schedule in the Telegram group. I'll put more quizzes and more images from the thing which I see on a day-to-day basis in the colleges and hospitals. Let's see. Let's learn together more. Fine. Thank you for your time. And the name should be changed tomorrow. Whenever I come live again, I would expect you to have a not in front of your name. Fine. Thank you. Bye-bye everyone. See you.